Yeah, okay, very good. Well, good morning, everyone. I think we'll go ahead and call to order our symposium this morning, our meeting, and we're really grateful to have all of you here for our American College of Surgeons Surgical Healthcare Quality Forum Houston. This is one of 7 such symposia that are happening across the country. We're delighted to have with us this morning quality care representatives, performance improvement teams, surgeons, CMOs, you name it. We've got quite a distinguished group here in our audience from each and every one of our each one of our institutions in the medical center that touches surgery. So I'm just delighted to have you all here, and it's really a great opportunity for us. Dr. Randy Bailey and I are co-hosting this symposium at the request of the American College of Surgeons, on behalf of the American College of Surgeons, and Dr. Bailey is going to take it from here.
Thank you, and good morning, and thank you for coming. I'm Randy Bailey. I'm a regent of the American College of Surgeons and chief of colorectal surgery at Methodist. I'm also pleased to be co-hosting this meeting because Barbara and I have both spent our careers in surgery and care deeply about ensuring that we preserve the kind of environment that allows great medical and surgical care to be delivered. There's perhaps no better venue to have this discussion than right here in Houston, where we're proud to be the world's largest hub for medical innovation and education with all of the distinguished institutions that make up the Texas Medical Center. That's why we have partnered with the American College of Surgeons to conduct this forum and participate in a larger dialogue nationally through the series of events that Barbara already mentioned, dubbed Inspiring Quality, Highest Standards, Better Outcomes. We believe that if physicians, surgeons, and hospitals are better engaged in the important dialogue around improving surgical quality, we're in a better position to help drive programs that deliver better outcomes and increase the value of health care. As medical innovators, we also keenly understand the importance of ongoing, rigorous medical training and education and the impact that it has on quality care delivery and outcomes. And you'll hear Barbara talk more about that shortly. Our intention in conducting these forums is to spur discussion about what medical profession, and in our case, we as surgeons can do to make things better and ensure the highest quality care. In fact, we're already doing a lot, but we know we can do more, and our hope is that we'll leave here today perhaps with an idea or two more that how we might affect change. I'll begin by providing an overview of the American College of Surgeons Inspiring Quality Initiative. Then we'll move on to learning more from Barbara about how education and training fit into all of this. From there, we'll introduce our distinguished keynote speaker and panel. We've reserved about 20 minutes at the end for audience questions and answers. Surgical quality matters everywhere in the country, but we've taken special pride here in Houston because we are truly world leaders in medical innovation, education, and research. As I alluded to earlier, the title of these forums is Inspiring Quality in Surgical Healthcare, quality improvement programs that improve outcomes and reduce cost. That theme is intrinsic to who we are as a college. It's highly consistent with what other leading organizations are currently focused on as well, such as the National Strategy for Health Quality Improvement driven by the U.S. Department of Health and Human Services, the Triple Aim by CMS, which says improving the U.S. healthcare system requires simultaneous pursuit of 3 aims: improving the experience of care, improving the health of populations, and reducing per capita costs in healthcare. And last, the learning healthcare system that has been advocated by the Institute of Medicine. Quality is a shared interest and a shared mission, and it feels like stars are aligned for quality improvement. We believe it's critical to seize the opportunity to advance the quality agenda. It's, after all, how the College of Surgeons was founded and what we've been focused on for the past 100 years. For those not familiar with the college, American College of Surgeons has led national and international initiatives over the last century to improve quality in hospitals, as well as the more specific fields of trauma, cancer, and surgical quality. Our experience through the development of programs such as the minimum standards for hospitals back in 1917, the Joint Commission in the 1950s, and the ACS National Surgical Quality Improvement Program, or NSQIP as we abbreviate it, in 2001, which we'll discuss in detail, has yielded systems, methodologies, and approaches that measurably improve the quality of care, save lives, and prevent complications. And in doing so, we also reduce costs. A central tenet of American College of Surgeons has long been that surgical quality improvement programs must be based on proven tools, systems, and methodologies that measurably improve patient care. The end results idea has served as the foundation for the college's 4 guiding principles in the continuous quality improvement cycle. These principles, captured nicely on the quality cubes that you have in front of you, are summarized here. First, setting the standards that are backed by research and focused on individual patients so that providers can choose the right care at the right time and in the right setting based on the patient's unique situation. Next, building the right infrastructure, including the articulation of appropriate structures such as staffing levels, number and type of specialists, and the appropriate equipment. Robust data, the identification of ways to measure outcomes through rigorous data based on medical chart review, not administrative data that may miss up to half of complications. That these things track outcomes after the patient leaves the hospital and is part of a continuously updated database. And finally, verification to complete the circle, subjecting ourselves to external review to verify the right processes and infrastructures are in place, that outcomes are being measured and benchmarked, and that hospitals and providers are proactively responding to these findings. That's really our bond with the public, to have a verification program that assures them that we're saying what we're doing and we're doing what we say. We think it's important that people understand the process because we shouldn't try to recreate the wheel when it comes to surgical quality improvement. We have far to go, but we also have a good process that is proven to deliver better outcomes. That program that probably captures all of these elements the best is ACS NSQIP. The reason we're so confident about NSQIP is it shows without a doubt that hospitals using the program can improve quality and reduce costs. If you look at the results of this study published in the September 2009 issue of Annals of Surgery, it evaluated 118 hospitals that began participating in NSQIP between 2005 and 2007. You can see that hospitals participating in NSQIP each prevented 250 to 500 complications annually. Hospitals of all types, large and small, urban and rural, teaching and non-teaching, improve the quality of care and reduce disparities. 62% of hospitals participating saw improvement in morbidity, and 66% saw improvement in mortality rates. If we extrapolate these kinds of savings to all hospitals across the U.S., look at the cost savings we would achieve. Average savings per hospital, $2.9 to $5.8 million. Potential yearly savings across 4,500 hospitals, $13 to $26 billion. Estimated total savings over a decade of $130 to $260 billion. That's almost enough to pay for the SGR deficit. These per hospital reductions in savings are not theoretical, they're real. This concept of mutual benefit, lower costs, and higher quality is captured in this diagram that shows there's a common ground in healthcare and we have a shared interest and mission to deliver inspired healthcare solutions. When quality improves by preventing preventable complications, such as avoiding that surgical site infection or urinary tract infection, we not only improve the patient's care, we reduce costs. To conclude, we have a brief 2-minute video that captures, I think, what we're all talking about. It summarizes nicely the college's quality commitment in 2 minutes. So keep in mind that the video moves fast. We'd like to show it because we think it captures the key points about quality in an interesting way, some of which we think we may want to discuss at the question and answer session.
I hope you all enjoyed that little great little video there. It's always fun for we surgeons to see. It's a little flashy, but I think it makes the point. And I got to say that over my time in surgery, one of the most fun things and important things I think I got to participate was in the forming of the NSQIP way back when in the era of the VA healthcare system, working with people like Shukri Khoury, who were really the founding fathers of this incredible program that was later adopted by the college. This system works. It lets us identify problems. It lets us find areas, hotspots for improvement, and I can't tell you how important I think it is, in conjunction with all those other standards that also work as well. But I want to focus on a different topic this morning, and I think that all of us recognize that we talk a lot about processes and environments and teams, and those are all incredibly important things. But another really important thing is the quality of our surgeons and the quality of our surgical workforce. And this morning I'm going to talk to you about a program that we are developing at Methodist in the heart of this Texas Medical Center, and actually every single institution in the medical center that touches surgery has been to visit MIghty and participated in our programs, called MIghty, the Methodist Institute for Technology, Innovation, and Education. Our premise is that here in the Texas Medical Center, education has been such an incredibly important gift that this medical center has given to our healthcare community. As you know, we have 2, 3, 4 medical schools, 2 that live here on our campus. Dr. Rial is here this morning from the Texas Medical Branch, and the other hot schools that are closely aligned around here in Houston. We produce a lot of future doctors. Our pipeline is strong. We also teach them to be the doctors they're going to be in our teaching hospitals. At any given time, we have over 2,000 residents living somewhere on our campus. We have over 3,000 medical students in our immediate environment. We really create that pipeline. But when you get right down to it, who takes care of you? It's not those students and it's not those residents. It's those surgeons in practice. And we have, at any given time, 90% of our workforce in that big red ball on the left side there that has to be good, not for 5 years, not for 10 years, but for 40 years. These are long, long careers. And you think about how our lives change every moment, the environment in which we surgeons live, and all proceduralists and all physicians. But we proceduralists are different. We surgeons are different. We get one shot to do what we're going to do right. And so we have to really be at the top of our game all the time as the world around us changes. And I just think back to when the first CT scan came out when I was a resident, those little black and white blurs that I think many in this audience will remember. This is how we see the world now medically. We may not like robotics, all of us, but let me tell you, it's coming. In every single discipline we have, our technologies are going to change. They're going to be better for our patients. They're going to be less invasive. They're going to be more precise. They're going to be more focused. It's going to take us a while to get there, but we are going to retool our surgical workforce over the course of that career. We can't have people be good only when they first finish with us. We have to retool, retrain, refocus if we're going to have the highest quality surgical procedural workforce to meet the needs of our country. It's not for us. It's to provide the best quality care for our patients. Think of how we manage gastrointestinal leaks these days. Not the way we did when I was a young resident, I can assure you. So our premise is that 40 years in practice is a very long time. There's no question about it. We have surgeons sometimes in practices longer than that, as we all know here in the medical center. But certainly all of us are going to last 30 years, probably 40, and maybe 50. And our fundamental premise is that a skilled and up-to-date surgical workforce is essential to high-quality surgical care. To that end, we have developed over the last 7 years a program called MIghty, the Methodist Institute for Technology, Innovation, and Education. What is it? It's an educational resource for healthcare professionals in practice who are seeking to maintain excellent skills and to acquire new ones. It will improve patient safety and quality through these educational pursuits, and we will conduct research on skills acquisition and technological development. So it's both an educational, an innovative, and a research resource. Many of you who live in this environment have seen this building come out of the ground over the last 4 years. This is our Methodist Hospital Research Institute. It's bundled right there in the heart of the medical center between all these other wonderful institutions right across the street from MD Anderson, next door to the Texas Heart Institute, across the street from Baylor. We're right in the heart of the place, and we're delighted to be surrounded by those partners. There on the 5th floor is a magnificent facility that's 35,000 square feet. I'm going to walk you through the design of this place and show you how it's built and to provide high-quality efficient learning environments to fully trained healthcare providers who are there to add an incremental skill to retool, refresh. This is our footprint, our 35,000-mile footprint. When you walk in, you see a really zappy space. This place looks different. This is not down in somebody's basement. This is a high-efficiency learning environment with lots of little spaces where learner groups can get together to talk about what they bring to this learning environment, what they're looking for out of this educational and training experience. When you walk in, your first thing will be to sort of learn what you came there to learn. We're going to take you to our virtual surgical amphitheater. Everyone knows, and this is that the way we surgeons like to learn is by watching masters or others who know how to do what we want to learn how to do. That's how we learn in the first place. That's how we learn throughout our careers. But not everyone has access to that immersive experiential learning once you're in practice. How do you recreate that environment for physicians in practice? Up here at the top is the famous Agnew Clinic, this beautiful painting by Akins. And as you see, back then, there were all those wonderfully engaged eyes looking down on the master surgeons trying to do a procedure on some poor soul. We then have switched in our lifetime to sort of this model. We all kind of huddle around, look over the top, and say, yeah, I think I see it, I think I get it. It's a tough way to learn, and certainly it doesn't have the hands-on experience that we really need to feel and learn a new procedure. We brought to our experience a new virtual amphitheater, which is a wonderful environment, a small amphitheater that's connected to all of our clinical spaces, so you can look very precisely through whatever view you want into our operating rooms and procedural rooms or other rooms throughout the medical center. We have the AV technology that's been developed to do this throughout our medical center. You can talk back and forth. You see what you want to learn. If you're a nurse, you want to see how the room may be set up or the technologies. If you're an anesthesiologist, you want to do one thing. If you're a surgeon, you want to see something else. We train healthcare teams in this environment. We then take you back to our procedural skills learning laboratory, which is really a unique resource across the country. This is 18 complete operating rooms. We can set this up for orthopedics, otolaryngology, minimally invasive surgery, the abdominal tract, whatever it happens to be. We can replicate this in our learning environments. We can set up whole operating room teams, and we do so allowing the faculty and the learners to move between spaces. We can use animate or cadaveric or explant models to train on these high efficiency models, which really allows you to touch and feel the tools, the devices that you will need to effectively, safely learn in a non-patient environment the skills that you need to stay at the top of your game throughout that 20 to 30 years. We can't have you learning on our patients. That's just not okay. We then have a number of research environments that I think are sort of looking to the future. We have fully capable CT operating rooms. In the future, our procedures will all be image guidance. The time of using just our eyes to see what we do is going to come to an end, and we need to learn how to do those procedures highly and carefully. We are just in the process of building out a hybrid MRI operating suite, which allows us to use the highest technologies most safely and to train the teams to work in these complex environments. We also, of course, have simulation. We have a virtual hospital that allows us to rehearse whole teams and train in those complex, rare things that happen in a hospital environment that are hard to be prepared for unless you've practiced somewhere else before you happen to run into those. And, of course, there are the basic partial tasks where you can do the basic hands-on skills that are necessary to safely adopt a new tool or device. We're very interested in also learning how best to define that you got the work, you got the message here when you trained with us. How do we best know when a surgeon has acquired a new skill? Well, it turns out that your facial thermal map is a fairly revealing structure. When you are stressed and learning, your face has a distinct thermal profile. When you're a master, i.e. have fluently absorbed that new skill, your face gives us a very nice, cool picture. So we are also very interested in learning when a surgeon comes to us or a proceduralist of whatever type comes to us, did you get it or not? We'd like to know that before we send you home and say, come back next week or you're good to go. Similarly, we want to know how we can help you when you go back home. How can we use the technology tools that are out there today to really help you when you've come and learned there with us? You go back to your practice, you try it once, it's not the same. How can we be an asset to you in your operating room? What are the tools that we need to do this well? What are the policy aspects around that? How can we help someone who's far away where we don't hold privileges there necessarily? It's a very important legal and procedural policy matter. What have we done to date? Well, we've had over 10,000 professionals come through Mighty since we started our program in 2007. We've been in our new building for almost 2 years. We've had surgeons and proceduralists, healthcare providers of all sides from around the world and the nation. Every single one of the institutions that are represented here that are part of the medical center have served as faculty in programs at Mighty. And we really do consider this a research platform facility to serve the needs of the medical center. And I think we need to work on getting that message out more effectively than we have, however. This is not just a unique program that we've come up with here at Methodist. This is a core program of the American College of Surgeons. The American College of Surgeons has a national network of accredited institutes that focus on educational curricula, training, faculty development, and we just happen to be the one that is focused primarily on physicians in practice. We believe this is a gap in our educational infrastructure. We believe that we have the opportunity to create a research platform here that will define how best to do that, to meet the needs of our surgeons over that course of their careers. And we really look to the wisdom of our surgical community here in the medical center to help us to get there. I thank you for your attention, and we'll be happy to answer any questions later. Thank you.
Our keynote speaker, Congresswoman Sheila Jackson Lee, seems to have been detained, so I think we'll move forward with our panel, and then hopefully we'll have an opportunity to hear from her a little bit later. Dr. Bass, I think, is going to introduce the
Yes, I wonder, can we have our panelists come up, and then we'll move on from them. What we're going to hear about now is the way different organizations in our medical center have really tackled some of the issues in quality management, performance improvement, specifically as related to surgery. We have an incredibly, as you see, we have a group that represents many of our member organizations, if not all of them. And really, I think we'll have a very dynamic set of presentations. I'm going to introduce them all at once at the beginning. First, we have Dr. Michael Chabot, who's the Chief Medical Officer at Memorial Hermann System, has a long-standing record of service to surgical quality measurement and improvement, primarily in the development of the National Surgical Case Log System. That was Dr. Chabot's baby, and I think we're going to hear a lot about how that system and other registry systems have benefited surgical performance. Dr. Tom Aloia is next to him. Dr. Aloia is an assistant professor at the surgical oncology, assistant professor of surgical oncology at MD Anderson. He's an HPV surgeon, has been instrumental in the development of quality measurement tools in that discipline and in the development of quality development teams, and I think he's going to talk to us about that. Next to you is Dr. Ken Maddox, who I think everyone in this room knows very well. He's the Distinguished Service Professor in the Michael A. DeBakey Department of Surgery at Baylor College of Medicine, but he's also the Chief of Staff, Chief of Surgery at Ben Taub, a legendary surgeon, member of the surgical community here in Houston and nationally, of course, an internationally renowned trauma surgeon. Next to him is Dr. Taylor Rial. Dr. Rial is an associate professor at the University of Texas Medical Branch. She is a outstanding health services investigator in addition to being an HPB, that's hepatobiliary pancreatic surgeon. And she leads a health services research program at UTMB. Next to Dr. Rial is Dr. Kevin Lally, who I think many in this audience know as well. He is the Surgeon-in-Chief at the Memorial Hermann Children's Hospital. He's a professor, he's the McNeese Chair in Pediatric Surgery at the University of Texas Health Sciences School of Medicine, and a very distinguished leader in the field of pediatric surgery. And last, of course, and certainly not the least, but the only non-surgeon in the group, Dr. Richard Wynardi, who I think we all know as the President and CEO of the Texas Medical Center. And he's going to summarize the comments and speak about the role of education and the commitment of the medical center to quality. So, if we could begin by having Dr. Chabot. Would you like to go first?
All right, thanks very much. Can you hear me okay? Good. Well, I think Dr. Bailey outlined the call for quality and safety and improvement in quality and safety in all of our activities. And I think locally and nationally, We all hear that call. Probably not so well understood by the public yet, but becoming better day by day. My own healthcare system embarked in 2006 on a journey to become a high reliability organization on the order of air traffic control, commercial aviation, and such, to prevent all avoidable harm. And that includes surgical harm as well. And we have some of our champions and abstractors, our NSQIP champions and abstractors here in the audience. For preventable harm like hospital-acquired infections, about 20-odd patient safety indicators, 8 hospital-acquired conditions like retained foreign objects in surgery. By far, 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 the most common monthly report audited from our hospitals is 0. That's what it needs to be. All of our hospitals have gone over a year without a retained foreign body. We haven't had a transfusion reaction anywhere in our system since 2006 and expect to never see one again. That's what high reliability is all about. But what is that? How do you motivate surgeons in surgical practice? And that's really why we're here today. What we've found is that surgeons don't particularly respond, at least immediately, to articles in the Annals or JACS or the New England Journal or JAMA. They respond to their own data. They respond very directly and very positively to their own data, especially against a reference of national data. And that's, of course, where the American College of Surgeons comes in. Memorial Hermann participates, I believe, in all of the college's registries. All 9 of our acute care hospitals are participants in NSQIP. All 4 of our bariatric surgery centers are participants. Our level 1 trauma center, of course, is certified and participates in the trauma registry. And multiple facilities are accredited by the Commission on Cancer. We hold that to be incredibly valuable, and that data is used for internal improvement. I just have a few more remarks. One, Dr. Bass mentioned the surgical-specific registry, originally known the surgeon-specific registry, originally introduced as the ACS case log. This is an individual registry for physicians and perhaps hospitals not yet participating in NSQIP. And it was introduced in the college's meeting in 2005 and currently contains about 3.5 million case records from 4,200 fellows of the college that are participating by entering all their cases into the system. It allows individual, private, comparative performance reports for individual surgeons. And I think it remains a valuable personal surgical record. Almost all surgeons keep a case log. It's one that you can maintain on your smartphone or your personal computer and can be kept up to date at all times. One final word with regard to NSQIP. It doesn't seem to be apparent yet to all 5,000 hospitals in the country that participation in a nationally based general surgery registry was required by the Medicare inpatient payment regulations of 2012. And implementation and case recording was to begin by January 1 of 2012. That requirement remains in effect, and really all hospitals in the country with surgical programs should be members of NSQIP at this time. Thank you.
Thank you. Dr. Aloia.
Good morning. Thank you, Dr. Bass and Dr. Bailey. I would like to thank the organizers of this important event for the opportunity to contribute to the discussion of today's conference topic, the American College of Surgeons Inspiring Quality Campaign. Speaking for all of us in South Texas, we are so pleased that the college chose to hold this conference adjacent to the Texas Medical Center, where so many physicians, surgeons, and patients from around the world come for medical and surgical treatments. I've had the privilege of working at two of the hospitals in the Texas Medical Center, first the Methodist Hospital, and now the MD Anderson Cancer Center, where I am a hepatobiliary surgeon and part of a team of performance improvement specialists who work to enhance quality and safety at our center. During my time at the Methodist Hospital, I was fortunate to learn from Dr. Bass and Dr. Bailey about the commitment the college has to surgical quality and the opportunity that the American College of Surgeons NSQIP program has afforded providers and hospitals to measure, compare, and improve patient care outcomes. As many of you know, this program is unique in that it uses independent trained nurse data reviewers, standard and transparent definitions, and a rigorous statistical model to make risk-adjusted comparisons of hospital performance. It is based on these pillars that the NSQIP program has quickly been adopted by over 500 hospitals in the U.S., representing over 10% of all that perform surgery. The steep growth curve of the program is a direct sign that the surgeons believe the data that is being reported and are willing to use these data to change practice in their hospitals in an effort to improve their own patients' outcomes. When we examine outcomes in our surgical patients, we always need to remember that the success of treatment is ultimately determined by the direct interaction between a patient and a provider. It is because of this human aspect, like surgery itself, successful quality improvement is only achieved through a merger of art and science. Certainly, to improve outcomes, we need to critically and scientifically examine our processes of care, eliminating variability and wasted steps. But successful quality improvement strategies also require enough flexibility for providers to react to the unique characteristics of our patients and to alter treatment plans based on training, intuition, and experience to achieve the best outcomes. When any institution decides to address a quality issue, they therefore must achieve a balance between best practice and culture. An institution that tries to enforce a list of best practices without understanding the provider culture will not create lasting behavioral change. As it is said in business, culture eats strategy for lunch. Likewise, an engaged provider base without institutional support for quality improvement is unlikely to develop safer patient care practices. Both the hospital administration and the provider base need to work together to integrate best practice into their unique workflows and environment. This is where the ACS NSQIP program has, in my opinion, had its biggest impact. Having quality assessment data that both providers and administrators can trust has been key to bringing these parties together and merging best practice with institutional culture. Neither processes nor culture alone are likely to change if hospitals do not believe their quality data. Having your hospital's results compared to other hospitals' results always provokes anxiety, and we surgeons in particular have a special ability to think that the patients we treat are somehow more difficult and more ill than all others, invalidating any and all outcomes comparisons. NSQIP has achieved a rating as the best outcomes data set in all of medical practice precisely because it has successfully created risk-adjusted models that level the playing field and allow diverse hospital practices to reliably be compared. A terrific example of these dynamics in action occurred when we brought the NSQIP program to MD Anderson 2 years ago. Initially, there was significant reluctance on the part of the faculty to trust the outcomes data. Of any hospital in NSQIP, one could argue that the surgeons at MD Anderson had a legitimate point. Unlike most other NSQIP participating hospitals, we have a singular focus on cancer, with 40% of our cases lasting over 4 hours, 22% involving 2 or more surgical teams, and 10% involving reoperative surgery. With this case mix, we heard over and over, how could anyone compare our outcomes to others? In this way, MD Anderson posed one of the toughest tests of the NSQIP methodology. Needless to say, the initial pushback was great. But through education about the NSQIP methodology and repetitive, transparent internal reporting of our NSQIP data, both providers and the administration are coming to rely on the data to the point that it is now being used to prioritize our quality improvement efforts. What they realize is that the system was designed by surgeons for surgeons. that the data are reliable, and that the data can be used to guide the allocation of quality improvement resources in our institution. In addition to the reporting of institutional outcomes data, ACS NSQIP has also provided considerable training and education opportunities that have taught many surgeons at NSQIP participating hospitals about team building, surgical simulation, continuous quality improvement, and numerous other tools that have created culture change by empowering surgeons to engage in quality improvement. Largely due to these efforts, the college has created a groundswell of enthusiasm for surgical quality, a byproduct of which is today's forum. When physicians engage in quality efforts, we soon realize that quality improvement is a circular process. We assess our outcomes, identify our weak areas, examine the processes and culture that underlie our poor performance, make changes, then remeasure, and the process starts over again. Indeed, quality improvement is a pathway and not a destination. This is why the term best suited to describe the process that the ACS NSQIP program is facilitating at each member institution is continuous quality improvement. For the college, a focus on quality has been continuous as well. As shown by Dr. Bailey, over 100 years ago, the College of Surgeons was founded with the core mission to address the quality of surgical care in America. Continuously since its inception, the college has maintained this focus. The current campaign, Inspiring Quality, is therefore not new. I think it is simply the embodiment of the current version of these efforts. As a provider on the front lines, I am grateful to the college for providing academic, political, and professional leadership in this area, and for providing opportunities for young surgeons like myself to participate in its core mission to improve the quality of surgical care.
Thank you, Dr. Aloia. So we're going to interrupt the sequence here a bit and have our distinguished keynote speaker address us.
Today we're very lucky to have Congresswoman Sheila Jackson Lee here with us to share her valuable perspective on the state of healthcare here in Texas and provide insight into what our leaders in Congress are focused on as we continue implementing health reform in our state and in our nation. Congresswoman Jackson Lee is recognized nationally as one of the most effective and influential legislators in Washington. She's currently serving her 9th term in Congress, representing the 18th District of Texas, which is centered here in Houston. The Congresswoman has received numerous honors during her career in public service, including the National Minority Quality Forum Lifetime Achievement Award. She's also a founder, member, and co-chair of the Congressional Children's Caucus, and has served several years as a member of the Democratic Caucus Health Care Task Force. She's been a staunch advocate for education and health care on behalf of her constituents, which ties nicely into the focus of our forum. And we, of course, have appreciated the opportunity to present her with our perspective on quality improvement and education. Please join me in welcoming our distinguished keynote speaker, Congresswoman Sheila Jackson Lee.
Well, we should listen more to doctors, and I'm delighted to come this morning and have a moment to listen to doctors. And I thank Dr. Bailey and Dr. Bass very much for the invitation and both their understanding of early morning schedules and en route to Washington as I speak. I'm ESPing the airline for Mercy and Grace to get there to the airport. Help me out with that. Let me acknowledge the distinguished panel, many of whom that I've had the opportunity to work with, and thank them for their comments. Let me acknowledge both Dr. Chabot, Dr. Aloia, Dr. Maddox, Dr. Rial, Dr. Lally, Dr. Renerdy, and in particular say how long I've been working with Dr. Maddox on a lot of health issues. I remember first, of course, though this does not in any way comment on his belief and support of the Second Amendment, I remember there was a siege of gun shooting of children, and I called upon his distinguished knowledge of surgery and emergency medicine to give us guidance in how we should respond to that. And let me as well thank Dr. Renerdy for years of service, and I will tell you right now that I will be holding you in congressional contempt if you do not remain as a consultant and friend to this great Texas Medical Center. Let's give all of them a great applause, and particularly Dr. Inerti for his service and years of service. I do mean what I indicated, the importance of listening to physicians, and in this instance, the American College of Surgeons, who are focusing on a really key element, though you might not have thought so, of the Affordable Care Act. You know that I could not rise to the podium without weaving that into the great work that you are doing. I'm going to take this back to Washington. You may even see it on the floor of the House when I hold it up and express my appreciation for a commonality of understanding about what healthcare for policymakers is all about. I deal almost on an every other day basis with Health and Human Services, Dr. Sebelius, CMS. Let me first of all say, as a member of the United States Congress, if there's any constituents or constituency work I can deal with on the issue of Medicare or the issue of the regulatory scheme and the regulatory, sometimes you might want to say, difficulty that occurs with the overseeing of medicine and physicians and the individual work that you do, many in the hospitals, of course, please don't hesitate to call our office. We work continuously. We have a broad district that has a high percentage of medical facilities, but also medical facilities that treat the impoverished, if you will, or those who have challenges, and for that reason, we spend a lot of time dealing with HHS. I work closely with our United States Surgeon General, who I've indicated I'd like her to come back and see some of the innovativeness that we're talking about, not only under the American College of Surgeons, but what happens in the broad base of medical practice here in Houston, but also the Texas Medical Center. We most recently were talking about this plague, if you will, even though it is not in the thousands of West Nile virus, where Texas is the epicenter of this particular year of the West Nile virus, and as well, many of you have been reading about a number of other viruses that have now sprung up shockingly here in the United States of America. So quality of care, surgical care is enormously important, and let me thank your founder, Dr. Franklin H. Martin, founded the American College of Surgeons in 1913 and wanted to make sure that there was a clear focus for surgeons and quality of care. Now with the focus on evidence-based medicine, the growing ubiquitousness of electronic records, the use of transformative education programs for clinicians, such as the Methodist Institute for Technology, Innovation, and Education, that Dr. Bass leads, and the ACS' own National Surgical Quality Improvement Program, the ability of surgeons to scientifically and systematically better the quality of care to their surgeon, to their patients, is better than ever. We thank you, however, for being the purpose and the cause for which we can reach out to, for you have the scientific data. You have the clinical living test, and for most all of us, we are delighted that you perform your great talent and technology and technique and bring about life and longer life. We in Congress are very supportive of the ACS with the passage of the Affordable Care Act. We're on a path of affordable and quality care. Currently, there are a number of provisions that affect doctors, surgeons, and patients in positive ways. Accountable care organizations provide healthcare providers an easier path to work together and coordinate care and share in cost savings. I want you to tell me how those work. It gives most primary care physicians, this is primary, and a 10% incentive payment for commonly performed services such as office visits. And most importantly, it also gives general surgeons in rural and other shortage areas a 10% bonus for performing certain types of surgeries. The projected increases in 2011 from the incentives are $240 million for primary care providers and $10 million for surgeons in shortage areas. There are over 393 records of shortage areas of primary care, medical care, and include dental, mental health care in Harris County alone. While access to care is essential need for our healthcare system, the quality of care is equally important. This forum is vitally important because it addresses at its heart unsustainable increases in medical costs. Improving the quality of care, reducing medical complications, not only betters the morbidity and mortality of your patients, but also that of our future economic outlook. It is crucial that we are partners together And it is crucial that we as policymakers have a more give and take among surgeons and primary and specialists in the medical profession, specifically our physicians, in order to understand. I heard most often as we were drafting this legislation and many commentary about how this bill was put together. Most of it is, of course, ugly and unpleasant in terms of the interpretation, but actually there was real research, give and take, closed-door meetings, small groups, hallway conversation, trying to get it right. I do not suggest that all legislation that has been written is always perfect as it is initially written. I would venture to say, not being in the United States Congress, when both the 1964 Civil Rights Bill was written, 1965 Voting Rights Bill was written, and in 1965 Medicare was drafted and written, were those perfect entities for what they wanted to do. We all are glad that we have civil rights in this nation and that we live in a country that prides itself in the protection of our civil rights constitutionally under the First Amendment, the Fifth Amendment, the 13th, 14th, and 15th Amendment that talk about due process, freedoms of religion, expression, and speech, and access and association. We're glad for that, but we wonder whether or not if we did not have continuous oversight of the Supreme Court, whether you agree or disagree with decisions that have come, whether they would have been as good as they are today. We expect that the Affordable Care Act will have its series of reviews. Certainly we are grateful for however it was defined to be constitutional as a form of penalty that most of us call it. The Supreme Court interpreted differently, but we accept that it is a constitutionally premised legislative initiative. Its basis was not to penalize. Its basis was to broaden the opportunity for research and development, to enhance funding for NIH and the CDC, to ensure that there was local community access to health care so that federally qualified health clinics can designate by way of medical treatment, medical exam, that this individual needs to be referred to a surgeon rather than going to the emergency room for that care, meaning that assessment care because something bad happened that put them in a medical crisis. Isn't it better to have them examined in a federally qualified health clinic that they are in need of surgical care and hopefully referred to one of the outstanding surgeons that are in this room? The Affordable Care Act, and specifically its mandate to the Department of Health and Human Services, was to establish a national strategy for quality improvement in health care. Here we go again. NQS has and will continue to play a crucial role in improving the quality of care. It does this by developing national priorities and strategies to improve health care quality, coordinating health care quality at the federal level, selecting measures for use in federal quality programs, and to develop mechanisms to collect public data. So you are involved in that. Perhaps and most importantly, the ACA links the quality of care with reimbursement rates, as I said earlier. For example, it uses public reporting of hospital-acquired conditions, HACs, that are currently used by CMS for the adjustment of payments to hospitals based on rates and hospital-acquired infections. Despite the good intention of providers, it is only through incentivizing measurable metrics. That is our interpretation. We welcome the rebuttal and or the commentary that we can make a systematic improvement to health care in our nation. That is the matrix and the structure of the federal government's funding. We're here today to firsthand to hear from you all, to be able to establish and to understand what you have put in place. And I am delighted to lift up your show and tell and to thank you for the show and tell, which is to indicate that key peer-reviewed studies, 82% of hospitals decrease complications, 66% of hospitals decrease mortality, and that's 250 to 500 fewer complications per hospital per year all over the nation. I think you need to applaud yourself. So go ahead and applaud for those great numbers. And then, of course, the number that strikes out, $13 billion to $25 billion potential annual U.S. health system savings if ACS and the NSQIP results were translated across all hospitals. That is why I think that it is a valuable thing to mention this morning is that we want to be your partners. We happen to live in a city that I can brag about when I go to the United States Congress, and that is, of course, that we have the Texas Medical Center and all of the surrounding hospitals that feed into, either by referrals either by linkage because of physicians, and you are 100 years old. You can imagine what surgery was like 100 years ago, but look how far we have come. Then now we have a new sophisticated approach, and that is to match the surgical technology and sophistication, electronic records, the Affordable Care Act, the real emphasis on quality of care and access to care with what you have now initiated. Today we'll hear about those programs and how they can be adaptable to large, I hope, medium-sized and small hospitals. We need you in the Harris County Hospital District, the expansive system that continues to grow as we continue to fund it through Medicare and Medicaid. Many of you realize that the Affordable Care Act also provides, I think, a lifeline to hospitals by providing a level of uncompensated care. So that means that if there are those that come to your hospital and get the full and massive care, that they are allowed to then walk out of a hospital as opposed to walking in sick or coming in an ambulance. Sometimes, many times, you're left in hospitals with uncompensated care. The Affordable Care Act provides for that. And so today I'm hoping that as you are presenting, we will hear and you will be presenting where we need to improve, to learn how best to improve, and to make sure that we keep on improving, to decide that healthcare raises itself to the words of our founding fathers when they declared their independence in the Declaration of Independence. I love these words, for we all are declared as equal with certain inalienable rights of life and liberty and the pursuit of happiness. I love those words. Certain inalienable rights that cannot be touched. I believe that healthcare rises to that level. It rises to that level because it gives a child more of a lease on life. It allows a parent to see out the growth of their children. It allows a vibrant senior citizen to continue to live. And just allows a breadwinner, if you will, who has much to give to his or her family, the opportunity to be cured, or the opportunity to be treated, or the opportunity to be made better. And so this little matrix block that you have provided is a good thing to hold on to on the plane, or a good thing to hold on a debate on the floor of the House. I assume that is given to ease the tension that might come about, make me and members of Congress much healthier. So maybe if it is under $50, I can take this and may ask you to ship a bunch of them to the House of Representatives and the United States Senate. But I think it is enormously important to emphasize thank you for setting the standards, number one, which I believe are important. Again, I want to match the United States Congress as your friend, to build up the right kind of infrastructure and staffing levels, specialists, equipment, and checklists. Let me say to you that in the Affordable Care Act, we fund and provide extra funding to provide more training for health professionals, including physicians, many of whom we hope will go into surgery. And we hope we can partnership. Number three, use the right data. I hope the utilization of electronic records will improve utilizing and passing data from one facility to the next, from one state to the next, from one patient to the next. You use the right data from the medical chart, backed by research, post-discharge tracking, continuously updated. And then, of course, four, don't just trust, oh, I love it, trust and verify. And, of course, external peer review. For many of us who have seen an elderly parent go through the last decade of health care, maybe even up to the beginning of this decade, as I have, and going to hospitals and seeing my mother's charts that were huge and massive, unbelievable in terms of the fact that if she had to go, and what she did, go to other hospitals for the blank look of what to do. Where are her medical records? For whatever reason, she had to be in another hospital, or she might be visiting her children or her daughter who lives elsewhere. So I would say to you that today's session is one that I applaud, and I hope that my presence here today is a re-emphasis of the need for increased dialogue with all of you. This is a historic room for me. For just about 2 years ago, we held a health care hearing on whether we should do the Affordable Care Act. And we listened to physicians, pediatricians, and others to talk about at least some system to provide a broad access for those who needed access to health care. You're in Texas with the largest number of uninsured in the nation. We hope that we will have the opportunity to partnership with a smile. And I encourage you to encourage our leadership and our governor not to reject the expanded Medicaid that would then provide health insurance for many working Texans. Why have a disagreement over what is good? Find disagreement over what needs to be fixed. But the general premise that you're discussing today, quality surgical care, standards, improving hospitals in their ability to provide surgical care, should be commended, respected, and admired. Give us the benefit of the doubt. As policymakers, without the perfection of your knowledge, to work with us to ensure that we listen to physicians, we reimburse in the right way, we do not diminish your specialty, and we lift up the cause of this nation, which is that we all are created equal with certain inalienable rights of life and liberty and the pursuit of happiness. Thank you for your work. Thank you for the Surgical College, the American Surgical College, and thank you so very much for the service you give to your nation. Again, God bless you, and God bless the United States of America.
Thank you, Congresswoman Jackson Lee. Thank you so much for taking the time out of your important schedule to be with us today, and I just want you to know that we're also trying to communicate with the airline and hope that they work you in. Now we'll go back to our program with our panelists.
Okay, well, let's carry on with our panel then, and
Thank you.
we're going to look forward to having those cubes on the floor of the Congress. Please, very well, as many as you like. We've got them, and we may need to switch the order a little bit because I don't want to miss Dr. Warnerty's comments, who has a very important obligation as we add a new member to the Texas Medical Center today. Dr. Maddox, why don't you give your comments next, if you don't
Thank you.
mind.
My comments relate to Dr. Bailey's third slide. If you forgot it, I'll remind you that the American College of Surgeons Committee on Trauma was first mentioned there. And I will talk about how trauma has approached the comment there has to be a better way. There has to be a better way, whether it's in trauma care, surgical care, politics, writing bills, and we continually change by improving quality. It was beginning in 1949 when the first trauma center in the United States was established by Dr. DeBakey here, and our database began in 1959, and I still have a current record of every trauma patient since that time until this very day, as well as each surgical patient at the Bentab. From that database, we have made changes by looking at quality and determining there has to be a better way. Some of those have been the elimination of some treatment and the addition of new treatment. We now realize that raising the blood pressure, starting 2 large bore IVs, increases mortality. So in order to produce better quality, we do what is absolutely 180 degrees from what we did in the 1960s. I would like to re-emphasize what Congresswoman Sheila Jackson Lee said, and that is the 4 overriding principles of standards, infrastructure, data, and verification is the key to what you should take away from this location. It was the Committee on Trauma that in late 1960s, early 1970s, began to address these 4 overriding governing principles, and the trauma network then began to be put into existence. And from that trauma network, we address quality. This was long before all of the current activities on NSQIP and others. I'd like to pause a moment and say quality means different things to different people. That doesn't mean the way they look at things is bad, or necessarily the right or the wrong way. It's just different. Let me give you an example. If one is looking at appointment systems in a clinic situation, it may be one will say that quality is how long it takes to answer the telephone. And then they answer, we met our standard by 95% by answering the phone within 15 minutes. My view of a clinic operation is when you make a phone call to the clinic, how many clinic appointments did you actually make and how many people actually showed up for the clinic? Now, we both are looking for quality, but we ask a different question. Because of those differences of us looking at quality, much like blind men examine an elephant, there are different approaches. The hospital administration and the organized medical staff may have a different view on how to use data. The data we're talking about today is physician-directed, physician oversight, physician control of clinical data, not those process data that the hospital is looking for to keep the hospital moving. As such, then, we have created, because of data analysis, different individuals that look at things differently. The CMO of the hospital may look at one thing, the organized medical staff may look at another. Let me give you another example. We are focusing on readmissions, and CMS is looking to penalize us for readmissions. But readmissions have a direct bearing on length of stay. The shorter the length of stay, the higher the readmissions. And we must acknowledge those because we're looking at data from a different direction. Again, back to the American College of Surgeons Committee on Trauma, we have preventable deaths, possibly preventable deaths, potential and non-preventable deaths, and there are then readmissions. Take the sickle cell patient who actually you expect to be readmitted multiple times, and so a readmission in and of itself is not necessarily a bad thing, and a standard may exist that readmissions actually ought to be higher. If we look at decreased cost, maybe lab tests or x-rays might be indicated, or maybe they're not indicated. So one must look at the data to analyze them. The the regulatory agencies and professional organizations likewise look at data in a different way. The American College of Surgeons, the American Medical Association, the American College of Physicians may look at data in one way, the same data by the Joint Commission and other regulatory agencies may use the same data to look at something different. As we physicians are looking to create a better quality, we've got to ask the clinical questions and yet cooperate and work with our colleagues on the other in professional organizations and the like. We then have internal differences of looking at data. The emergency physician and the trauma surgeon may look at trauma data in a different way, one for a workup, the other for a level of treatment. So the emergency physician is looking to make a diagnosis. I'm looking to say, is surgery needed, and what's the results of those surgery, and then how quick can we get to the operating room. Yes, there are best practices that we measure quality on, but those best practices, by analyzing the data, by verifying that data, change over time. 50% of the operations I was taught as a resident no longer exist. 50% of the operations we now do and the technology we now apply did not exist when I finished my training, because we look to say there's got to be a better way by the way we analyze our data. We now know that lab panels probably aren't necessary in the trauma patient. We know that 95% of CT scans are probably not necessary or may produce a vomit. You know what a vomit is. Victim of modern imaging technology that leads to an additional test or an operation that maybe wasn't necessary. So as we look at the data, we've got to be able to ask the hard question to say, what is the better way to move forward? finally, a caution to us, with the electronic medical record and with quality, there is a temptation on the part of some agencies, maybe governmental, maybe regulatory, and some administrators, certainly not any in Houston, to use quality data as a punitive or disciplinary manner. We know from the airline industry that if you use data for quality in a disciplinary way, people then stop reporting that data. So we've got to create the discipline, the verification, and the changes, and let the disciplinary process be something totally different than our quest for quality. I applaud the College of Surgeons on this initiative. I really like the video that I saw, and thank you for your interest in taking this message on to a larger group. And remember the 4 overriding principles. Take your cube with you, send it to Washington.
Thank you, Dr. Maddox. No question that Committee on Trauma has just transformed many aspects of surgical care in this country. I'm going to take the liberty of the chair and ask Dr. Warnerdy to please go next because he has an important obligation he's going to have to leave us for.
I just wanted to add 2 things really under item number 2. One is the what are called here staffing levels, and I presume that means everybody else in the place other than the surgeon, and also equipment. With regard to staffing levels, we have 37,000 full-time students here, including nurses and pharmacists and technicians and therapists and all kinds of other people. And it is only recently that there has been a real effort to acculturate everybody together and to get the various healthcare professionals to talk to each other and share the different things they need to do to really help the quality outcome of patients. One thing that sticks in my mind is wound care. One thing that sticks in my mind is wound care. In most end-of-life situations, we end up with people with serious wounds, and it's very difficult to avoid readmissions and other things in those kinds of situations. But let me also speak for a minute about equipment. There is within the engineering profession, I happen to be an engineer, a lot of work on failure trees and how you keep equipment operating properly. If we're going to do robotic surgery, we have to start looking at the methods that are invented for space travel and for atomic energy, where they learn to have 5 nines reliability and to have things really keep working. Because I would immediately say that Murphy's Law is perfect, and if things are going to fail, they always fail at the worst possible moment. Lastly, I want to mention one thing that I think impacts the quality of surgery, and that is changes in the teaching of anatomy. In the Texas Medical Center, we have 9 anatomy programs, and none of which I feel safe in saying is as good as it might be. So in building the new medical examiner's office, we're going to go back 100 years and put a classroom around every autopsy table. And I don't want to say teaching in living color, but we'll be teaching in color. So you'll be able to find pathways and understand how parts of the body are anatomically connected, unlike now dealing with gray cadavers. So there are a number of things going on that I think will be very beneficial. I think it is wonderful what the surgeons are doing, and the talks today on quality and everything you've heard are simply wonderful. But keep in mind that the paradigm is going to change dramatically. We are going to go from a sickness care environment to a healthcare environment. Whether we like it or not, that's what's going to happen. And that means that a lot more emphasis is going to be made on prevention of illness and injury. A lot more emphasis is going to be made on keeping people well and changing really, I think, the paradigm to how we measure cost and outcome and what we're all about. I know of no surgeons who don't wish that they saw fewer sick people. And as we know, 1/3 of all of the people that we see now in the Texas Medical Center get here by self-inflicted wounds, by smoking cigarettes and using drugs for recreation and other things. So in conclusion, I think this is a wonderful example of what a group of professionals do when they seriously want to attack a problem. And this is a model for what will happen in virtually every one of the professional fields, and a great lesson to everyone else. And so I do hope those of you who are not surgeons will take back the message to everybody else in your institutions to listen up and see what surgeons have done. Try to copy it. Good idea. Thank you very much.
Thank you very much. Okay. Dr. Rial.
My research expertise is in health services or comparative effectiveness research, and our group uses primarily administrative data to study population-based outcomes and variation across a variety of disease processes. Administrative data refer to data that were not initially collected for research purposes. This includes things like Medicare data, which are collected by the Center for Medicare and Medicaid Services for billing purposes. It includes tumor registry data and linked Medicare claims, and the National Surgical Quality Improvement Program, or NSQIP data. Unlike the other data sources I discussed, NSQIP is unique in that the data are risk-adjusted, with detailed data collected prospectively and not deduced from medical claims. The use of these data sources, I want to caution you, requires significant training in biostatistics and data management and health services research methodology. It also requires in-depth knowledge of the data sources in order to know what questions can be answered, or more importantly, cannot be answered by the data sets. These data are often publicly available, and as a result, are often misused. Many health services researchers are not clinicians, and they're not asking clinically relevant questions, and conversely, many clinicians dabble in the use of these data sets, and in doing so, they make significant coding errors, they make incorrect assumptions, and they fail to recognize the limitations of these data. However, health services or comparative effectiveness research using administrative data, when done correctly, can play a critical role in the quality improvement process. Our goal is to use our clinical experience to guide our research questions and to translate our findings into improved quality of surgical care and outcomes both locally and nationally. I'll give you a few examples. When I came to UTMB, fewer than half of the patients admitted to our hospital with acute gallbladder disease did not undergo cholecystectomy, and our gallstone-related readmissions were over 33%. Two studies using Medicare claims that we did showed that depending on the admitting diagnosis, 25 to 57% of Medicare beneficiaries admitted with acute gallbladder disease didn't have their gallbladder out. And similar to our experience, their 2-year gallstone-related readmission rate was 38%. 50% of those patients required subsequent cholecystectomy, suggesting that we can do better. Based on these data, we implemented a quality improvement initiative in 2009. Our goal at UTMB was to perform cholecystectomy within 48 hours of admission, hypothesizing that this would decrease readmission rates, decrease costs, and improve patient outcomes. This is especially important for us as a lot of our patients are uninsured, and getting these patients out in a more costly manner allows us to treat more patients. This required a multidisciplinary effort and required significant culture changes Dr. Aloia talked about. To give one example, it was difficult to add on these cases during the daytime, and it was not standard to perform a cholecystectomy after the normal OR hours, despite the fact that we always have a general surgeon in the hospital to cover general surgery. Now we worked with everybody, and now it's common for these cases to be done in the evening or on the weekends. After pathway implementation, our cholecystectomy rates increased from 48% to 75% in the first year, and are now over 90%. Our readmission rates dropped from 33% to less than 10%. And in patients undergoing cholecystectomy, our time from admission to cholecystectomy and our total length of stay decreased by 2 days. This increased the cost on the initial hospitalization over $2,200 a person. Finally, our conversion from laparoscopic to open cholecystectomy decreased, and our complication rates basically didn't change. And this translated into significant cost savings and improved patient care. To shift gears, many groups have used NSQIP data to study outcomes and risk prediction in pancreatic surgery, which is what I do. However, these studies are limited by lack of pancreas-specific variables and predictors in the NSQIP data, such as the use of drains and pancreatic fistula. Together with the ACS and 53 NSQIP institutions, we have started a NSQIP demonstration project, with all 53 of these institutions collecting additional pancreas-specific variables. Initial analysis of this data set showed that there's significant variability in technique among surgeons performing pancreatectomy. And this provides targets for studies to look at the comparative effectiveness of these different techniques and provides targets for subsequent implementation of quality improvement measures in pancreatic surgery. Finally, our group is focusing on using administrative data to evaluate the comparative effectiveness of surgical treatment options in older patients. In older patients, treatment is more complex because these patients have the benefits and harms of treatment vary based on the coexistence of multiple associated chronic medical conditions. Secondary data analysis of observational studies allow us to study a group that we can't look at in randomized controlled trials. And with novel statistical techniques, we can control for selection bias. And we may be able to identify specific combinations of chronic medical conditions that are associated with high treatment-related morbidity and mortality for whatever disease process we're looking at, and therefore would negate the benefit of aggressive treatment. And conversely, we can identify subgroups of patients in whom aggressive treatment is beneficial. This would allow us to risk stratify patients, provide this information to physicians and patients for shared decision-making, and to avoid futile care that is expensive and unlikely to benefit patients. With that, I'll just move on to Dr. Lally.
Thank you, Dr. Real. Fabulous applications and work. Dr. Lally is going to show us we care about patients at all age groups, and please.
Including children. So children are different. They're not little adults. And if we look at the outcome measures that are currently broadly utilized nationally, things such as time to balloon for MIs, venous thromboembolism prophylaxis, MIs, hospital readmissions, et cetera, almost every single one of those is adult-driven, and very, very little are specifically related to children and children's surgery. And in point of fact, to my knowledge, there's only one risk-adjusted outcome variable for children's surgery available in the United States, and that is outcomes for congenital heart surgery. Relevant to this discussion, those data were derived and driven by surgeons because they wanted to have surgeon-specific outcomes. Those data are going to be required to be reported by children's hospitals doing congenital heart surgery next year on a national level, but again, those are the only data available. As many of you may know, NSQIP the college embraced NSQIP after the VA initiated it, and hence it has largely been driven as an adult-oriented program. The American Pediatric Surgical Association became very interested, where most pediatric surgeons are heavily involved in college activities, and sometime around 2004, 2005, our Quality and Outcomes Committee at the APSA began to integrate with the college to see if we could develop a pediatric-specific program for risk-adjusted outcomes for children's surgery. That group, led by Peter Dillon and Keith Oldham, really have done a lot of work. They initially had an alpha test with 4 freestanding children's hospitals around the United States to create initial data sets and variables, looked at that initial data, and then did a beta testing with about 44 children's hospitals, and have recently evaluated data from about 36,000 hospital discharges. And this program is still not quite ready for prime time, although we're getting close. Not surprisingly, there are significant differences. A lot of children's surgery is relatively low complications. As it turns out, most of our serious outcomes are going to be linked to newborn surgery. A lot of the morbidity exists in that patient population, and so how we roll out and compare different hospitals to each other in a risk-adjusted outcome is going to be very different for pediatric NSQIP as compared to adults, but we're definitely on that phase. I think it's important that these programs are physician and specifically surgeon-driven, and once you do have the data, the question then becomes, how do you change that, what's occurring in your own institution? And we began to look critically at that at our own children's hospital a little over a year ago, when we restructured ourselves in the operating room so that there was an integrated group of individuals responsible to just a small group of people. And we've created within that institution an infrastructure, which I think is very important, to look at safety and quality outcomes in the operating room. It's an integrated team. We have anesthesia and surgery that are kind of leading it jointly. We have created a safety committee that meets every week. We've created a reporting structure in the operating room. where we can have very simple cards that people write out after every individual case, and those are collated on a weekly basis. And we're now moving forward to take action on those things and then feedback to the team. As been discussed here in the past, culture change is going to be vitally important. I firmly believe that surgeons and physicians have to lead that culture change, but it's not going to be easy. We have to really relate how we relate to our hospital and our hospital partners and our scrub techs and our nurses is going to have to change. In order for us to get to the different level of quality that we have, we're going to have to accept a very different level of complications, much lower than we would view as okay today. It's going to be an interesting challenge, but I'm very comfortable that surgeon-driven will be able to do that. As a surgeon, we've always had an interest in doing the best outcome for our patients. So once we have those risk-adjusted outcomes, I think we'll be able to move forward. Thank you.
Thank you very much.
I'd like to thank our panelists very much for their succinct comments. We still have a few minutes for questions. The staff have some microphones that they can circulate to people. Before we start, I would, if Dr. David Berger is here, ask him, perhaps he may have had more experience and more time in dealing with NSQIP at the VA than even Barbara Bass. Dr. Berger, are you here?
I saw him earlier, but I think he had to leave, Randy.
Okay. All right. So we'll proceed with questions from the audience then.
Hi, thank you very much. Jackie Lappin, I'm a transplant surgeon. I think it's fair to say that probably everybody in this room is a believer, and you're sort of speaking to the choir. I guess as a lone voice, I would say, what's the single most important thing you would recommend bringing back to your hospital to entice them into developing such a program?
Anybody want to take that?
NSQIP brought us here, but there are other quality programs that exist. The message to take back is have a program. And NSQIP is very well organized. It does cost money, so you have to convince the administrator to spend that money. I would add the phrase, just like many other things we're talking about in today's world and has been emphasized by the AMA and the TMA, it must be physician-directed and physician-led. And those surgical programs need to be surgical-led. So a message from the surgeons is, we got to figure out a way to get our surgeons involved. They tend to want to go hide in the operating room, but you've really got to be part of this activity. You don't know what you don't know unless you have the data to look to see what you now know.
I guess I would expand that as a transplant surgeon, is that correct? Yeah, talk about a highly regulated oversight kind of surgical practice. You've kind of lived with this in a different way, longer than any of us have in the more, quote, general or other surgical domains. Your opportunity to have a program is already governed by your outcomes, and your payments, of course, come to that as well. So I think one message I would additionally provide is that this is coming from a regulatory perspective, and so we all need to be prepared for what is coming to be going to be driven by our payers. And the trick here is to create systems and programs that we as surgeons and healthcare providers, and I'd modify Dr. Maddox's suggestion a little bit, surgeons need to be engaged and have leadership voices, but this is a team sport, and our health services investigators, our nurses, our everybody who's part of that complex healthcare team has to be equally engaged in this process if we're going to build a system that's really going to transform the quality of care we provide. So I'd say go back to your place and see who's interested. What programs are there to build those teams with and get to it, knowing that somebody else is going to give us something else if we don't.
Dr. Chabot, as somebody who comes from an institution that has all of the different programs, could you expand on that?
Well, let me just make a point that the key is really using the data that's provided and using it wisely and quickly. Those of you who may not know, hospitals, acute care hospitals are actually required to report to 5 registries. Cardiac surgery registry, cath lab cardiology registry, stroke registry, nursing sensitive care registry, and most recently, a nationally endorsed, risk-adjusted general surgery residency. That's the way it reads in the regs. Doesn't specify, none of the registries are specified by name. There happens to be only one risk-adjusted general surgery registry that I know of in the United States and anyone else that I've ever met, and that is NSQIP. So the data are going to be taken from those registries by CMS. They will be published, key measures will be published on Hospital Compare. It's really imperative that our surgeons and everyone else associated with that data take action to improve quality first before the data are published publicly. You're going to see it first in your own hospital. I'm already beginning to see results from our individual hospitals that need to be used there in their departments of surgery, specifically for our NSQIP data. We just joined NSQIP at the beginning of this year for all of our hospitals, and we're just beginning to get actionable data. And I must say it's very interesting to review it. Dr. Peterkin, can you stand up, Dr. Peterkin? Dr. George Peterkin is Chief of Staff at our Southwest Hospital. He's a prior Chief of Surgery, and he is our NSQIP champion. We're happy to have him, and I don't know if you've had a chance to start reviewing your individual hospital data. Yeah, but it's, I got a peek early. Thank you.
And if I could augment that in terms of getting the data to the people who have an impact at this. At Methodist, about 6 months ago, we initiated a provider-specific report. Just as Dr. Chabot mentioned, there's nothing to motivate somebody but to give you your own performance relative to a group, because as Dr. Aloia said, we always believe it's our patients, it's not really us. And I got to say that the driving force there was not that I want to see everybody, that Dr. Bailey and I, we did this program together, want to see everybody's results. We want to give it to the physicians and let them see how they compare so that they'll become engaged and realize this is not just about them. This is about our processes of care. This is about the appropriate utilization of SQIP measures and other measures. So it's just sort of giving you a glimpse of what's coming, and I think the NSQIP data has great credibility among surgeons, so that's the data we form our report around. And I think it's been quite an informative process. It hasn't changed things yet, but it's been very informative to the surgeons.
Any other questions from the audience?
Just so you will know that you're not alone, 8 different posts on Twitter have occurred in the hour that you've been in this room about this conference in this room. Did you do that?
May I ask just one more? I'd like to ask Dr. Real a question, and that is, you are unique in the sense that you bring a much greater use of administrative data, the stuff that we as surgeons have kind of said, oh, that stuff's no good. How can you make that a credible, how have you made that a credible product that have allowed you to really deliver those incredible results relative to cholecystectomy in your patients?
Again, I think you have to realize the limitations of the data and know what you can study and what you can't study with them. I think a huge danger of administrative data is if we're going to let policymakers make decisions on administrative data where they don't understand the clinical issues, they don't understand what those data can and cannot answer. I think also, we do those studies to look at population-based outcomes and variation, which is a nice way to study things, because whenever you look at a disease process and you see variation in care, it suggests that there's room for improvement in standardization of that care. But then you can't stop there. Then you have to take those administrative data and bring them back to your institution or to get a group of pancreatic surgeons across the country together, if you don't do enough of those at your institution, to then start to bring change where you're actually collecting clinical data. You're looking at NSQIP stuff. You're looking at real registries of clinical data that bridge the gap between administrative data and those sorts of things. We want to use NSQIP data for pancreatectomy, but again, even that wasn't adequate to study what we wanted, so we're doing things like the demonstration project. But you have to come at it from a multidisciplinary approach and not just use the administrative data, and you have to be very, very careful about how you report that. And the other big issue in administrative data is selection bias. So when you're looking at outcomes, if you're going to look at patients with prostate cancer, it looks like patients who receive treatment do much, much better. But if you look at their non-cancer specific survival, they do much, much better because the healthier patients are getting treatment. So we're looking at a lot of statistical methods to even be able to evaluate comparative effectiveness.
And I would say that's lesson number 2. We need more surgeons who can talk the language of health services, quality metrics, and investigation. And it's a big gap in our repertoire. As Dr. Maddox said, we all like to go to the operating room, but we need people who can do this work and are really trained to the same quality of scholarship that we have as an example here with us this morning.
I'm sorry that Sheila Jackson Lee left, because I think there's another message here. She asked us to help her make the appropriate quality changes. As we look at our requirement from the feds to use antibiotics in the operating room on certain cardiovascular cases, and we look at the organisms we have dealt with on the last 10 years, those antibiotics they are requiring don't hit the bugs that normally cause the infection. So we use their drugs because they required it. We don't get paid if we don't use their drugs. And then we use the antibiotics that we need to be prophylactic against the organisms that we see. So we need to be able to have the same feedback loop to CMS and to the federal government to make those required changes when best practices of the past need to be changed to be new practices for the future. And quite honestly, this is a message to the national organizations. We have not had that luxury. It's been a one-way street for communication, and quality works for all of the stakeholders, including government, in this entire process.
Okay, any further questions? Well, if not,
Well, I'd like to thank the panelists, the participants, all of the audience for taking time to come to this forum to deal with what we feel is a critically important issue to us, to our hospitals, to our patients, and as Congresswoman Jackson Lee said, to our country. So thank you. I hope you take home a message to you, your hospital, and your constituents, and thank you again for being here with us today.